high, that normally it's 340. I don't know if Dr. Byatt's on the call, if she could maybe expound on that a little bit, but she had received quite a bit because the 103 is really high. And, it didn't feel like she had an infection. So I went through that and felt like maybe that was too much side attack.
I see that Dr. Lin has her hand up.
I had a similar question. So now, at what point, at what gestational age do you decide to use Pitocin? Because this fetus was 25 weeks. Because I know it's second trimester, you do the side attack, but at what gestational age do you use Pitocin?
I mean, you can obviously, as a clinician, you can use your own clinical judgment, but I think the recommendations from like SFP, you can use side attack like up until 28 weeks. Like in the second trimester, you can use that protocol, but I don't think it would be wrong to switch to Pitocin at the time of the side attack not working at this point.
I see that Dr. Bayat has her hand up.
Hi, good morning. I wanted to chime in a little bit earlier, but I was dropping my daughter off at the bus stop and there was a little bit of drama. But thank you, Natalie, for a good presentation. So I think that Dr. Sagaram is correct. The usual protocol for labor inductions, either for demises or for induction terminations, depends on the gestational age, but usually the most common dosing used is 400 Q3, and there's data that you can see in the SFP guidelines that references the interval between the dosing being much more important than the actual dose itself. So a lot of times when you're using the 600 dosing, you get more side effects without necessarily having a more effective or successful induction. So usually it's 400 Q3, and most protocols now don't have a starting or loading dose of 800 anymore either. In terms of switching to Pitocin, there's no evidence that Pitocin is more effective. So most terminations, at least up until 28 weeks, still involve the combination of mifepristone and misoprostol. Unfortunately, when we're looking at data beyond 28 weeks, there really is not a lot of data out there, but at least most of the practices in the country that are providing abortion later in pregnancy up until 32 or 34 weeks are using misoprostol and not Pitocin.
Yeah, as I said, there's like an SFP new guideline that came out maybe like a week or two ago that I think that it would be great if we could reference that. I sent it to all the residents. I just can't remember it on my top of my head.
All right, well, thank you, Natalie. Excellent job.
Dr. Ebert, let me know.
All right, well, in just a minute, I'm going to ask Dr. Saluki to introduce our ground round speaker. But in the meantime, just a word or two about attendance. We'll be taking attendance at 8:10 using the participants list in the WebEx. So if your name is listed clearly, you'll get full credit for attendance. If you are not listed clearly, or if it's a phone number, or if there's more than one person at a station, then you can email your attendance to me or Michelle or Beth. And with that, Dr. Saluki, are you ready to introduce our speaker?
Yes. Good morning, everyone. Good morning, Dr. Lerner. So exciting to see you. And I'm honored to introduce a really wonderful physician, a personal mentor this morning. I'm going to tell you a little bit about her. So she's actually originally from Ukraine. And Dr. Lerner has moved to the United States as a teenager, where she completed her OBGYN residency at Mount Sinai and then completed a pelvic surgery fellowship in Virginia Mason Hospital. And Dr. Lerner actually has multiple board certifications in addition to her OBGYN board certification that she obtained in 2013 and then recertified in 19. She's also certified in focus practice designation in complex family planning. She has a senior board certification and also focus practice and designation in minimally invasive gynecology. So she definitely has like a very broad sort of pelvic surgery practice. And her interests are not limited to traditional urogynecology practice as well. I've personally seen how talented of a MIG surgeon she is, and she definitely has expertise in challenging conditions such as endometriosis as well. A little bit more about what she's done in the past. Previously served as NYU's director of simulation, and also continued a similar role at Montefiore, and that's where I had the pleasure of working with her as a fellow, and I learned so much from her. She taught me so much. And currently she's at Lenox Hill, which is where I did my residency, so part of me is bitter that I didn't get to really learn from her in residency as well. Her academic interests, as you'll see, include education via simulation and the relationship simulation has with quality improvement. She's well published in that area. And also advancement of minimally invasive gynecological surgery, and also advancing the quality of surgical care that we offer to our patients. She has authored multiple publications, including 32 peer-reviewed articles, and also essentially spearheaded several research projects, and has served as a peer reviewer for 4 journals, one of which includes the Obstetrics and Gynecology Journal, as well as Simulation Journal. And not surprising, she's received multiple 14 institutional awards, probably a little bit more than what I've just listed. Also 4 nationally recognized teaching awards. She's really is well deserved. She's a very gifted teacher. She, on a personal note, has always been gracious with me, generous with her time. To the residents, that 4th degree simulation that we did last year was all under Dr. Lerner's tutelage. I called her and she walked me through the steps again through video, like over a couple sessions, and spent a lot of time just walking me through that wonderful simulation. And definitely planning on getting some additional ideas from today's talk, and probably going to call her again to try and figure out how she did it. And I always appreciate the fact that she lets me pick her brain about how to do unique, unusual surgeries. And definitely always shares tips on how to achieve career goals as working moms. So it's my pleasure today to introduce you. Thank you so much for this honor. She'll be talking to us about the magic of simulation, and taking a peek behind the scenes is the title, and I'm looking forward to it.
Thank you so much for this great, generous, kind introduction. It's so wonderful to see former colleagues and friends, and it's really an honor and a privilege to be here and share my ideas on the topic I'm really passionate about, which is simulation. Can you hear me okay? Is the sound and video working?
It's loud and clear.
Great, and feel free to ask questions. I'm happy to pause and dive into details if anybody has a question. In this talk, I will discuss the importance of simulation in modern day medicine and hone in on the nuances of surgical education via simulation. I actually want to broaden today's discussion beyond surgical skills simulation training, because it will be relevant to what I will bring up later in the talk. So while it is an oversimplification of what modern day simulation is, common categories are team training for obstetrical emergencies such as postpartum hemorrhage, for example, labor delivery, or in the operating room scenarios such as emergency undocking of the robot. Surgical skills composed of basic, advanced, and procedural, and interpersonal skills such as communication skills, using standardized patients, or tackling complicated topics such as periviable delivery. The reality is that the field of simulation has undergone explosive growth in the last 40 years, and we have gone very far beyond those common examples. Team training, task training historically started out in anesthesia and ICU specialties. It then was pretty clear that CRM, which stands for Crew Resource Management Principles, borrowed from aviation, and task training such as intubation, quickly demonstrated performance improvement and improved outcomes. This type of training quickly expanded in other disciplines and specialties. And while initially the push was to prove that simulation works to justify the time and resources it takes to run simulation programs, in the last 2 decades, there have been so many publications on how it improves patient outcomes that now regulatory agencies are looking at how to integrate simulation into their processes. As a field, we decided we don't need to be proving that simulation works anymore, but we need to focus on how best to use and implement it and how to advocate for our work to make sure we get the resources that we need. Realizing that simulation training is now an essential part of clinical life, professional organizations and regulatory agencies started to take action on local, state, and national levels. ABOG, for example, also has been piloting use of shoulder dystocia simulators to assess skills during oral boards, for example. In an effort to reduce maternal and perinatal morbidity and mortality, the Joint Commission created new simulation requirements 2 years ago for the accreditation of labor and delivery units, mandating postpartum hemorrhage training in preeclampsia simulations. We explored this topic in a recent publication, sharing our experiences in building in situ simulation programs on labor and delivery units across different practice settings to help other simulation programs with programmatic development. The basic structure is simple. Get a labor and delivery team together, which means everyone who works in L&D will participate over the course of 2 years. Run a clinical scenario of an obstetrical emergency such as postpartum hemorrhage, eclampsia, hypertensive crisis, shoulder dystocia, maternal cold, core prolapse, and then debrief together as a team to reflect and deep dive into how and why. Learning objectives for these simulations cover not only medical knowledge and skills, such as medication management, for example, but also teamwork principles such as leadership, communication, situational awareness, and mutual support. You also need a simulation team, a pioneer to jumpstart the program, but also those who will get trained in simulation techniques and will take over the program. I'm thankful to my current simulation partners, our nurse educator, our MFM labor and delivery director, for doing this important work. While a simulation session may seem like 2 hours of intense training, it takes many more hours of preparation. We work hard not only to make scenarios feel real and arrange for logistics such as attendance, but also to interface with moving parts of the hospital, such as blood bank, to get input from all involved parties, and to create a process for which latent safety threats discovered during simulations can be addressed. This brings me back to the why of simulation, which goes beyond the primary objectives I have just described. While published evidence shows that all of the effects you see listed here take place, I wanted to share with you just a few examples in real life of what we have been able to accomplish in a few months since we started a new program at Lenox Hill Hospital. We updated postpartum hemorrhage protocol and with practical tips for clinicians, worked with the pharmacy to create uterotonic kits for easy access in the medication refrigerator, and stocked non-refrigerated postpartum hemorrhage meds on the postpartum hemorrhage card, updated PPH card based on clinician input, worked with the blood bank to create a tip sheet for clinicians to obtain blood products and updated MTP protocol, invited blood bank supervisor to attend a postpartum hemorrhage session, which was an eye-opening experience for them. Now we have an ally in the blood bank who can help us straighten this relationship further, and created a process for labor and delivery teams to interface with leadership and voice their concerns and suggestions, and created a process for new hires to get immersed in labor and delivery workflows during simulations. Now let's backtrack for a minute and take a peek behind the scenes. My academic career in simulation education started 13 years ago at NYU. I knew nothing about simulation but loved teaching. My chair told me I had good teaching scores, and if I was interested, I needed to go figure it out because our hospital was building a brand new simulation center at the time, and our department needed a simulation program. I was fortunate to have the mentorship of wonderful simulation faculty at the Simulation Center, and that is where I got the advice to take a week-long course at CMS, Center for Medical Simulation at Harvard. CMS is a think tank of simulation innovators who also teach clinical faculty like me and have been running simulation instructor courses for over 20 years. They have PhDs in education and organizational psychology with expertise in cognitive psychology, fields that study ways in which people learn and function best at work. Just to give you a taste of the extent of scientific work in those fields, books for laypersons have been written to summarize key findings and approaches. Armed with evidence from studies and experiences working in large organizations, CMS team members have written a series of how-to articles on a wide variety of topics in simulation. One of the most valued Lerner articles is an article on how to debrief. While it is pretty clear that to get certain results, you need to have influence over actions, Unless you dig deep enough to get to the frames or minds of persons performing those actions, you will not be able to reach and maintain a high level of performance. The goal of the advocacy inquiry model for debriefing in this article is to see events through the eye of the participant and understand their frame of mind. And it is accomplished via advocacy, stating a fact and observation, and inquiry, asking a question. Let me give you an example. As a debriefer, I may state the advocacy piece like this. I saw you as a leader of the OB team, and you did not call for MTP for this patient who was in stage 3 hemorrhage and was rapidly deteriorating. I know that MTP is the standard intervention in this stage as a part of the response algorithm. Inquiry. What was running through your mind at the time? Participant may answer. Right. Well, now that I think about it, I agree that I should have called for it when our QBL was close to 2 liters and she became tachycardic and dizzy. To be honest, I was distracted by the patient's mom who was in distress about her daughter and could not focus on the patient. But even if mine was not there, I would hesitate to activate the MTP. My understanding was that many products are wasted if you don't use them, and that the blood bank gets upset when that happens. Debriefer. Thank you so much for sharing your thoughts with us. Let's talk more about role delegation and family support during emergencies. And also let's go over the rationale behind our blood bank protocols and how MTP plays out from the standpoint of the blood bank. Now that you see a taste of how a specific discussion might fold out, also I would say, just like with debriefing methods, CMF authors wrote about methods to assure a safe learning environment in the article you can see here. How to structure a debrief in general in an organized and systematic way. And as you can see, this takes practice and time to master. After all, the books have been written on the topic. And we also have an International Simulation Society, which has a large annual meeting and a journal, Simulation is Healthcare, for which I'm currently serving as an associate editor. There are close to 30 simulation fellowships in the United States, and I'm very happy to say that my simulation team at NYU started the first OBGYN simulation fellowship that we ever know of, which graduated 3 fellows. Of course, there are many challenges, especially in how to scale this up and disseminate simulation to clinical spaces. That's how the idea of clinical event debriefing arose in a simulation community, with the thought that we need to take debriefing and learning tools developed for simulations into clinical day-to-day life. While many L&D teams debrief their hard cases, the idea here is to apply simulation techniques to most, if not all, clinical events. Of course, time is limited, and you can't do a full 45-minute debrief on every clinical encounter, but you can focus on one aspect of it and use simulation tools to learn from daily clinical work. Debriefing every vaginal delivery, C-section, every surgery has so much value. I hope you can see where I'm going with this. For example, several years ago, my colleagues and I put together a major vascular injury simulation for MIGS fellows at the annual fellows course at AAGL. As you can see, we were able to replicate the operating room environment, and our model was realistic enough to get the fellows engaged. While we had a rich debrief after the simulation, during which we covered important medical and surgical management details, along with team-based training principles, one of the important points that fellows brought up is how they will then manage this in their home institutions. This made our participants think that we now need to bridge the gap between what we think is ideal performance and how we can then implement it in real-life environments. In gynecologic surgery, we need to start thinking beyond the basics of surgical education and interface with our institutions locally and nationally, and taking control over quality in surgical care. Now imagine for a minute what would happen if I had a magic wand and one of my wishes was that JCO would create accreditation requirements for simulation training to improve the quality of outcomes in gynecologic surgery and all the other clinical spaces. With regard to the team-based training alone, we would then be able to run gynecologic surgery emergencies such as major vascular injury, fire in the operating room, and emergency robot undocking, for example. But beyond team-based training basics, we would then rehearse complex cases, such as combination cases involving multiple specialties and services. Task workflows in our units, for example, that would be like, what would it be like for a standalone ambulatory surgical center to add major cases such as hysterectomies to their list of cases that they can do? disclose adverse clinical events and complications, and address all aspects of those events, from prevention to downstream sequelae management. Walk through difficult concepts with Chinese and staff, such as pre-op management of medically complicated patient with the choice of a route of hysterectomy. This result will then trickle down to the positive consequences of culture change, which will result in improved work environment. Simulation can not only make sure that our surgical lives in the OR are safer, more efficient, and more rewarding, but it can also combat system problems, make an impact on all of the isms such as bias, racism, and misogyny. Imagine gender bias training for clinicians paired with a simulation that addressed the same concept discussed during didactic portion in groups, which then allowed participants to practice what they just learned. That would be my magic wand. Now let's shift gears to surgical skill simulation training. While it is still based on evidence and science of learning, we're now honing in on mastery learning. Before I dive into the details, I would like to acknowledge that an elephant in the room, as this often comes up when we talk about simulation in general and surgical simulation more specifically. As surgeons, we know that heart surgeries are hard no matter how skilled you are. Same with surgical education. First, surgical education and simulation are highly complex, constantly evolving processes that are under-resourced on many levels. And in addition, we're only starting to scratch the surface of understanding mastery learning in peak performance in surgery. One highly realistic simulation of laparoscopic hysterectomy or even large-scale national mandates such as FLS will not fix problems in surgical education, no matter how effective the single information might be when implemented correctly, which is hard to do in itself. Furthermore, being a change agent is difficult and may result in moral injury because of opposition obstacles we face in our work. Yes, yet if we do not act as change agents, we lose our sense of identity. This suppression of the internal drive to advocate for trainees and patients also results in moral injury and burnout. As a result, we're stuck between a rock and a hard place. Moreover, to move the needle, we need to break down silos between specialties, disciplines, and fields. If we got nurses, anesthesiologists, surgeons, sociologists, organizational psychologists, anthropologists, psychometricians, AI innovators, and implementation scientists together, just to name a few, we would make much more progress than what we have been able to accomplish so far. Even more importantly, we need to get the word out to the public so that patients, regulatory agencies, and the government and society at large can allocate appropriate resources to let us do our jobs. Speaking of breaking down silos, as I mentioned earlier, Make It Stick is a go-to book for anyone who wants to learn and teach. It decodes and translates the research in the field of cognitive psychology that pertains to the science of learning and explains evidence-based learning strategies using real-life case studies. This is an example of how learning strategies from Make It Stick were integrated into practical advice for medical educators at the Mayo Clinic. To demonstrate the value of understanding the best ways to learn based on evidence, we can look at learning styles as an example. It is a common belief that people receive and process information differently. Some learn better from visual materials, while others from written text and editory sources. However, it turns out that matching one's style does not result in better learning. It is more important than what is more important than the mode of instruction matches the nature of the subject. So, for example, using visual aids for geography. Another example is making learning effortful by providing opportunities for the learners to struggle before giving them clues and answers. That's a point listed in item number 2. Yet another is mixing it up by changing the conditions and presentation and the use of simulation, which also allows for learning in a safer environment. And that's a point listed in number 4. Another important concept is cognitive load theory. Current thinking is that information is first processed in working memory before it is encoded for retention. Working memory capacity is limited, so we need to break up what we're trying to teach into digestible components. Leaders in surgical education pay close attention to this. For example, the American College of Surgeons recommends that educational materials are designed to limit the level of cognitive load. Here is an example of an instructional design on an article that we published that includes ideas mentioned in the prior slides. When I was at NYU, REI faculty and residents have been having a hard time teaching and learning premature menopause and HRT. The topic is complex. It is difficult to apply what residents read and heard in lecture to patient care. So instead of annual PowerPoint lecture, we utilize case-based learning. In addition to reducing cognitive load by dividing the material into digestible segments, we also engage them in effortful learning by asking them to think through simulated cases and role play. In addition, we mix it up by adding mini lecturettes, for example, how to interpret lab values in details on prescribing HRT formulations. Finally, our faculty was supervised in small group discussions and corrected mistakes. We use the same model to implement case-based learning for management of prolapse, for example, but it is applicable to any area. Now let's look at another example, how to address the topic of teaching clinical correlation to pelvic anatomy. In this teaching session, we'll utilize the following principles. Integrate several sources of information in teaching modalities such as a hands-on cadaver lab, anatomy primer, and with photos, videos, illustrations, and a text uses a dissection guide, as well as surgical atlas and textbooks. In addition, we actively enroll participants in effortful learning by engaging in several activities. First, they construct anatomic models to help them think through the basic relationships between structures. Next, they use hands-on models for pre-med organs to address high complexity surgical principles. Finally, the virtual reality pelvic anatomy simulator shown here allows learners to mix it up by utilizing tactile, visual, and auditory inputs. It also allows learners to take the pelvis apart in layers, breaking up the information into smaller digestible segments. Shifting gears, I'm going back to the complexity of mastery learning in surgery. We know that we need to break up complex tasks into simple components. In addition, we need to pay close attention to the learning curves. In domains such as sports and music, it is commonplace, yet it is very slow at making its way into surgical education. I will now share my journey in surgical education research and use some of the examples and mistakes I made as examples. My interest is developing low-cost, high-fidelity simulations that allow for real-life implementation outside of few well-resourced simulation spaces. Some of you might recognize prompt shoulder dystocia training in the picture on the right. And on the left, you can see the inside of the pelvis and make it yourself uterus and pelvic structures. So a research question was, can we use a self-made, low-cost, high-fidelity vaginal hysterectomy trainer for teaching and competency assessment? Our goal was to help learners teach what we call OR-ready proficiency level before they participate in live surgery. First, we had to do a validity study to understand how learners of different levels of training and exposure perform in this model. I'm passionate about vaginal hysterectomy, so early in my career, I was trying to figure out the best ways to teach it. This is just an example of how the performance metrics were studied and published on in a great journal. So that's our preceding index publication. It is difficult to teach and learn for many reasons. And to list a few, we have upside down anatomy, a different approach to pathology, narrow physical space, different instrumentation, narrow field of view, and the importance of using multiple assistants effectively is key. First, we ask ourselves, can we assess competency? And luckily at this time, this landmark paper you can see here in a great journal addressed competency assessment in the operating room, which means we had a solid starting point. After understanding baseline performance scores, we decided to study the best way to teach using our model. We focused on junior residents, those that were not exposed to vaginal hysterectomy in the operating room, and randomized them into one-on-one coaching session, led by either a trained peer, another resident, or attending surgical educator, which was me. We did not see difference between two groups because one session captured residents very early in their learning curve. It didn't matter who did the training. The curve was steep and everyone improved. A better way to answer our research question would have been to put residents through serial, we think 4 to 5 weekly training sessions, make it stick principle from point number 5, and then randomize them into peer versus expert coaching to see if there was a difference in the plateau phase of their learning curve. An RTC of this sort is going on right now. It is NIH sponsored, and one of our colleagues, Doug Miyazaki, who is created a MIA model, a commercially made vaginal hysterectomy training, is running this randomized control trial. Another important lesson we learned from the study design standpoint was that the cognitive load was too high from doing entire procedure, even in a simulated setting. Practicing a series of tasks and skills allows learners to master them before putting it all together in a procedural training. For example, to learn the steps of the procedure and anatomic concepts, we have a milk carton model you can see on the left upper corner. To learn clamping, cutting, and suture ligating in a narrow space, we have a wonderful partial task trainer designed by Dr. Leslie Kameyer in Wake Forest, seen in the video on the right, is demonstrated by my daughter. We have several task trainers on the top of the slide. I call them PVC pipe models, which add to the complexity. And finally, when putting it all together, learners work on flow, efficiency, retraction, and the use of assistants and a procedural trainer like the one we created, seen on the video in the center. I want to focus for a moment on the FVS, It stands for Fundamentals of Vaginal Surgery Project, pioneered by Dr. Peyton Schmidt, a urogynecologist at Michigan. The idea that you can break down high complexity procedures into simpler parts to learn them before putting it together is not new. However, her 3D printed model and low-cost inserts make it standardized and replicable and allows for easy dissemination, which is a big advantage. You can see the tasks listed here that she included in her project, which are standardized and well-defined. What is remarkable is the trend that we see in surgical education towards a competency-based, longitudinal, stepwise curriculum, which then will allow the creation of a surgical portfolio of sorts for trainees, rather than the high-stakes one-time exams such as FLS with questionable implementation issues and major validity problems. Issues that she encountered in her rollout are virtually identical to what I found in my FLS training program, which I'll share with you later, and you can see them listed here. While the FLS pioneered the idea of curriculum in a test, the FRS, Fundamentals of Robotic Surgery, broke it down into a stepwise process with well-defined milestones in what I call mini exams. And FVS takes it to the point of asking when this should be implemented, perhaps before the R debut, and how it should be integrated into training in general. You might then wonder why there has not been a formal FOS, Fundamentals of Open Surgery simulation curriculum, but we're currently trying to figure that out. My take on this is that our simulation community is looking for nuanced, flexible, complex solutions rather than a magic wand. So this brings me back to reality. Having built simulation programs in several hospital systems over the last 13 years, I would like to share with you the highlights of what I've been able to accomplish in my current institution, a community hospital-based program in New York City in the last year and a half. Here you can see the list of simulations I conducted in the last year, in addition to the obstetric emergency team-based training I described earlier. On the top left, you can see the incisional closure and a partial tusk strainer in a preparation for a C-section, procedural simulation after our FOS, Fundamentals of Open Surgery training, and a fourth-degree repair using a beef tongue model. Here you can see the videos of operative hysteroscopy, who knew that peppers were such a good uterus, and a TLH with the model made from animal tissue. It's created by Gynesum, a company that focuses on low-cost, high-fidelity, real tissue models. And if I had to pick one topic to teach RIA simulation, it would be electrosurgery. I'm currently working in a publication to make this available to other educators. My another personal favorite is a total abdominal hysterectomy simulation. This model is self-made, low-cost, high-fidelity, portable, and deployable anywhere. One of my goals is to make sure that all programs that want to utilize simulation but do not have the funding to buy expensive commercial products have access to and the know-how. I hope that by now you have seen medical simulation through the eyes of simulationista, and you can see how there is a sim for anything you want to teach. This is an example of several simulation models used for teaching sacrocolpopexy, uterosacral ligament suspension, and sarcospinous ligament fixation from my urogynecology colleagues. But shifting gears to the robotic surgery training pathway for a moment, in brief, the pathway consists of phases or parts that residents need to move through before they can do live surgery at a console. The timing varies. For example, we do dry lab or hands-on training on bedside assisting skills for interns during orientation. Then meet with them to orient them for the console virtual reality training. And then we do dry lab part 2, which consists of 5 console tasks, 3 of which are suturing, as you can see for images on the overhand side of the slide. Residents have to pass those tasks before they can sit. Finally, we encourage them to log their console cases, which then would be useful for their civil institutions, either fellowships or hospitals from the credentialing standpoint. I call this an educational sign-out, when the institutions communicate between each other with regard to the training that was performed in previous institution. Robotic surgery is ideal for virtual reality simulation training because you do not lose fidelity in transferring your skills from virtual reality training to laparoscopic instruments. You're training with a computer, which is the VR trainer, and operating with a computer, which is the robot. This pathway has been studied by robotic educators that have formed robotic training network and have been adopted by numerous training programs across specialties. This body of work is referred to as FRS, Fundamentals of Robotic Surgery. I use this document to remind my residents of what they're expected to be doing and keep track of what they have completed. I send out an email to robotic surgeons letting them know when a resident has completed all of their training and is consult ready. Many of you already know about FLS, Fundamentals of Laparoscopic Surgery, which is a curriculum and an exam that consists of didactic parts and manual skill simulations created by general surgeons over 20 years ago. ABOG made it mandatory for OBGYN residents to pass this exam before they could sit for their boards. Recently, EMIGS, Essentials in Minimally Invasive Gynecologic Surgery, which is specific to gynecology and was created by AGL, has been approved by ABOG to be used instead of FLS and is expected to replace it. Atul Gawande wrote a great article in the New Yorker over a decade ago entitled Personal Best. Here he points out that all surgeons, just like elite athletes, need coaches. No matter how well trained, we need guidance to maintain our personal best performance. Let's take a closer look at the surgical coaching model using FLS and EMIGS training as an example. EMIGS is similar to FLS in its format, so what I'm going to say about FLS also applies to EMIGS. I spent a lot of time and energy figuring out how FLS works, so I partnered up with other mixed surgical educators across the country, and we reviewed the articles in early literature and laid out validity evidence behind the FLS as a high-stakes exam while I was implementing FLS training on the ground. The validity of educational assessments is a complex topic, but if we're going to use simulation in high-stakes exams, such as FLS and EMIGS, as prerequisites for board exams, we need to understand simulation not only is a learning tool, but also as an assessment tool, which are two separate domains. One of the challenges is that there are three main frameworks. Classical, you might have heard of face and construct validity, for example. MESICS, shown here in Keynes, and the latter two are now being accepted as a standard in modern education frameworks. There are 5 types of validity evidence in MESICS framework, and evidence components are constructed into an argument for or against using a specific test as an assessment tool. When applied to FLS studies summarized in this table, we concluded that there was not enough evidence to use FLS as a high-stakes exam for OBGYN residents. Most of the supportive evidence was weak, and it mostly consisted of comparisons of performance between junior and senior surgeons, and some of the evidence actually pointed against its use. Once I dissected out the FLS for myself and had a deeper understanding of why FLS was limited, I got ideas on how to compensate for its deficiency. One issue was that it was not GYN specific, which EMIGS addressed. However, my main take-home message from this was that it's best to have junior level residents take the exam before they start operating. That is when they get most of the simulation out of the simulation training. And their basic skills will translate into lower complexity cases such as laparoscopic cystectomies. I realized that we need to be deliberate about how we're teaching and implementing FLS. I also realized I need to time the exam correctly. Motivation to learn is a complex and multifactorial topic, but as this article points out, having to take a test is an undeniable factor. I found that in cases where FLS test date was not set or was delayed for logistical reasons like COVID shutdown, residents did not practice and their skills decayed quickly, so they had to relearn skills once they mastered, which took time. That is how we settled on the order of events. Set the test exam first, then schedule training sessions several weeks before the exam. Now, let's backtrack for a minute and look at how SAGES, an equivalent of ABGO-CREAG in general surgery, which oversees FLS, presents this. As I mentioned earlier, their premise is that residents would just teach themselves to do FLS from official FLS videos. If we think of this from the mastery learning standpoint, that delivers the wrong message, implying that you can teach videos, you can watch videos to teach yourself surgery, and it ignores everything else we know about the science of learning. The other issue is that what might have been best practice 20 years ago is no longer evidence-based. We now know education and simulation are constantly evolving. Now let's look at the official FLS documents they put out at the time of its creation. Here you can see the proficiency metrics residents are supposed to meet during their training before they take the test, which are based on time and errors. Now you can see how many takes it took for novices to practice each task to become proficient. For example, task 1, which is peg transfer, was repeated 57 times on average. In task 5, intracorporeal knot, 119 times. However, we do not know exactly how passing scores are calculated, as they're considered proprietary. And even though we can estimate estimate those from what's been published on FLS, that is not the point. How can we run a race without knowing the goal distance or the time? Aside from the lack of transparency, there is no acknowledgement of things like deliberate practice and coaching, which we know are key to mastery learning. The concept of mastery learning has permeated performance in multiple domains, from first grade to concert calls. Why is it that we're not hearing about it in surgery all the time? After all, my daughter learned about a growth mindset in first grade, and they continue working it in second grades. Our minds are growing. We have to adjust to that. We have some catching up to do. In this example, my goal was to figure out the most efficient and evidence-based way to teach FLS. I learned quickly that it is less efficient to train in a group, even in a small group. While larger groups might be more efficient from the standpoint of the instructor, when I added up time and effort it took to get residents to the same level of proficiency, because I was measuring it, it was taking longer. Because my coaching was spread thin and the residents ended up taking longer to learn. Other logistical strikes against the group sessions, in my opinion, in favor of individual sessions, were that we can work around individual and rotation schedules to figure out ideal spacing for learning and self-practice. That is how I settled on individual sessions. I also noticed that junior residents, which was our target group due to the lack of exposure to laparoscopy, were struggling the most with 3 dimensions of reality conversion to 2-dimensional monitor, the biggest issue in laparoscopy early in your learning curve. To help with that part of their learning curve, my mixed fellows and I built a partial task trainer. You can see here on the left. We called it a laparoscopic platform. We use it for intracorporeal suturing tasks, for example. And we do those tasks on the platform without the monitor or the camera and without the laparoscopic box trainer. And then we go to the box trainer. That cuts down on frustration and training time. And now we're having fun learning. Next, I needed data on learning curves, how residents are getting through the FLS training. I'm grateful to residents and fellows who supported me in Montefiore. And since I settled on individual coaching sessions, I knew that I would be able to collect metrics, which are time and errors from those 2 sessions. And then I could ask residents to record their scores in between and during self-practice. Then, since I would have access to the FLS scores from the residency program, I would compare their final scores to their practice scores to get an idea of where you have to be as a resident before you take the exam. Based on the performance during the training of 50 residents, which also included more novice second-year residents, it is nowhere close to the FLS metrics I showed you earlier that have been pushed by SAGES and is an ideal way to prepare for the exam. I learned an important lesson. If you create high fidelity, customized, personalized, and competency-based surgical coaching training program, you will have short learning curves and efficient and effective learning. Another important caveat I wanted to share with you is that we need to think beyond basics and consider what it would be like, what it would take to be fluent, not just safe, enough to be OR ready. Dr. Martin Levy, an orthopedic surgeon at Montefiore and a brilliant simulationist, is an innovator in our field. Here, he's being featured on NPR's Hidden Brain. Aside from his work in surgical coaching to make it psychologically safe, he has done very interesting work on using low-cost, high-fidelity models to employ high repetition, very deliberate practice to establish fluency prior to the operating room exposure. Of course, it helps that he is also a residency program director, and it also helps that in orthopedic residency, interns do not enter clinical spaces for a month in July, and that whole month is dedicated to their onboarding. Some of you know about the work that Kara King and Caprice Greenberg are doing in the realm of surgical coaching. And to become a surgical coach in the academy, which I am, I took a day-long course in coaching to understand frameworks and tools. We use those tools to do video coaching with my mixed fellows. As you can see from this graph, surgical coaches and simulationists are using the same cognitive learning theories. And just like debriefing and simulation, Academy has created an organized and tested way to standardize coaching. It addresses not only technical skills, but also all the other factors that play into performance. And I think it is essential that we start integrating all of these wonderful tools in our daily lives. This brings me to the end of my talk. This is a quote from my mentor and simulation guru, Dr. Brost, a brilliant MFM simulationist who researches mastery learning and MFM procedures. I hope I painted a picture of what simulation could offer to back up his statement. We can teach our trainees more efficiently, faster, safer, and more deliberately than what clinical exposure alone can offer. Thank you so much for your time, and I'm looking forward to your questions.
Thank you, Dr. Lerner. Thank you so much for this excellent talk. Are there any questions? Oh, yes, Dr. Saluki has her hand up.
Thank you so much for this talk, Dr. Lerner. It's just you do incredible work. I am getting messages from from residents and colleagues about how like they're just like, oh, can you do a vaginal hysterectomy sim? So I'm gonna have to contact you about how to set that up. But my question is, what do we do? It's gonna take this is something that takes like years of expertise, and like I think it's just gonna take some time and patience to set up a lot of the things that you've mentioned. It requires some resources. So my question is there any way, we can ship over some of our residents over to your sim centers for, for some simulation? Because my question is like, does it make sense to kind of reinvent the wheel, or while we're reinventing the wheel, can we, is it possible to set up simulation centers for residents that you can just send to?
Yeah, I love that question so much. It's super insightful and incredibly advanced. And you're 100% correct. What our simulation community is looking at right now is regional simulation courses. In fact, one of my close mentors and simulation colleagues, Grace Chan, who's your gynecologist at Hopkins, is doing exactly that. So she started a regional simulation course at Hopkins, and they draw residents into their program to do exactly as you said. Same thing with Wake Forest. Leslie Kameyer, aside from inventing task trainers, she also does regional courses. So I think you're 100% right. Reinventing the wheel is the worst thing possible. And even though the simulation community, we always share all our resources constantly, it still requires, as you know, for you to call me and for me to send my materials. And also sometimes it requires for me to go to you and bring my models or show you my models, or sometimes we even have to work on them and modify them to fit your learning objectives and your needs, right? So there's quite a bit of adjustment and work involved in that. In fact, as an example, to kind of echo what you said, at SGS, Society for Gynecologic Surgery, at the education committee there, which where I'm a member, we actually are, trying to start a simulation consultation service so that people can call in, email us, and do exactly that. Basically, it is set up a conversation, if possibly a visit. So I 100% agree with you. Where it comes, I think, a little bit challenging is merging institutional resources, especially if those institutions belong to different health systems. So, like for example, at Northwell, Lennox is part of it, is already doing that for intern bootcamp, for example. They pull all 4 residency programs for their shoulder dystocia training in their simulation center, because prompt shoulder dystocia trainers are kind of pricey, and you can't really make your own, force monitoring device for the baby's neck. So those are just like some ideas. But yeah, I 100% agree with you. That is key. And also another example, the regional courses for Urogyn fellows, as you know, right? Like Columbia ran one that we went to together. So I think it's headed in that direction. And the Simulation Society that I'm part of is also supporting that. And we try to start that in OBGYN SIG when I was active in there. So yeah, I think we're getting there, but I agree with you. I think it's a lot of things need to happen on a local level.
And that actually that reminded me of that Columbia sim course so any tips on how to get industry to support you in these sims?
Yeah, it's interesting because in your gynecology, industry shows interest because fellows are going to graduate and it's like an immediate horizon. So it is in their interest to do that. Same is true with simulation courses for professional societies. like AGL or SGS, for example, or even ACOG. I think it's harder when you're dealing with residents and learners, but not always. So like, for example, with gynosem, the mute model uterus that you saw, you know, industry realized, like it was Copper Surgical and Ethicon actually that realized like, yeah, we need to partner up on this and we need to do this for the residents because they'll be doing TLHs, you know? So I think honestly, a lot of it is like networking and finding out about those things by the word of mouth. So again, there's like no centralized process of how we can pull our resources together. ACOG had a simulation consortium, which was a big undertaking that was active for 15 years, but it recently got dissolved. So it's really just through simulation societies, regional collaboration, word of mouth. I think it's just also part of his culture change, as you know, because I've seen so many colleagues and friends from different institutions who kind of like went to different institutions that are now trying to build programs. So I think, as you said, it takes time and a lot of talking to industry and figuring out like what can you capture.
Thank you.
I see that Dr. Bayat has her hand up.
Hi, good morning. I'm in the car, so I hope that you can hear me and that I don't break up. Thank you so much for that really, really wonderful presentation. My name is Lily, and I'm one of our family planning providers here. And I did a lot of simulation work in my last job, so the topic is very near and dear to my heart. And the question that I have for you is, do you have any sort of pearls or secrets or advice about being able to get protected time or money in order to, you know, develop simulation programs locally at your institution? I know in my last position that was really hard, and we basically had to do, you know, a lot of the work on our own time without any additional compensation. So I'm just wondering if that is the pattern in most places, or whether there are people or places that have figured out how to get protected time and funding for this kind of work.
No, great question. I appreciate you asking that. That's sort of why I spent like 4 slides talking about culture change and the challenges, right? Like, I just wanted to address it up front and say, yes, it's really difficult. And you pretty much hit the nail on the head. It's all about the protected time. It's not so much about the simulators because, you know, you can build most of these yourself. And honestly, you don't really need a simulation center. You can do simulations in the closet, like at Lennox, because the space is so limited in general surgery. Department doesn't want to share their simulation space. We basically have what I call the mobile simulation lab. So we can roll out the simulations and do them in the conference room. Not all of them, obviously, I have to like, I have to, you know, tailor it to different things. But in general, it all comes down to protected time, as you said. So that's really key. In terms of, and most of it is unpaid labor, as you said. As a family planner, I can relate to that. But I would say it's very institution dependent. Like, for example, with obstetrical simulation, I think there's quite a bit of support with the JCO requirements. So that was sort of helpful. But also the thought is like maternal morbidity and mortality is on the front page of daily news. Like no institution wants to have their hospital end up there, right? So those are big drivers in terms of getting obstetrical simulation programs together. With gynecologic surgery, it's a little bit more challenging because the outcomes, the surgery outcomes are just different. They're tracked in different way, and there's also medical legal implications that are not as pronounced. So I don't have a good question for you, answer for you. I think a lot of it is about changing culture and institution, getting buy-in from upper leadership and saying like, yes, you need this FTE, you need this protected time. This is very labor intensive. If you want a high quality program, you have to undergo professional development. You have to build a team. So I don't have easy questions for you, except for it just takes time. You start really, the only advice I would say is, you know, you start really small and then you grow. And as people see the value of your work, then you're able to expand. But yeah, the time is the biggest problem for us. So, you know, the thought is like, okay, if I have a magic wand, you know, I can have an educational RVU system, and it's been attempted in other hospitals, but other than clinical RVUs, you can also have educational RVUs for your work, and that counts, you know, that comes into your pay formula. But still, either protected time or educational RVUs, whichever way you calculate it, it still requires local institutions to take that step, and that part is really challenging. So I don't know if you have other thoughts.
Are there any like funding opportunities or grants that faculty can apply for that sort of support until they're able to develop a more robust program?
Excellent question. I think from the standpoint of equipment, yes. So like, for example, where I'm right now, there is a donor, like a philanthropy department that helps support innovative educational projects at the hospital. So I applied for this grant twice. Once last year, we got money for the startup, and then applied second time around to get more funding for the equipment. But again, it all comes down to equipment, and the equipment itself is not that much. I have to say, I haven't seen grants that are targeting protected time for physicians. So I don't know. I don't know off the top of my head if that is an existing entity.
I see that Les Barta has his hand up.
Good morning. Thank you very much, Dr. Lerner, for the presentation. I just wanted to touch on two things. I'm actually the director for simulation within the School of Pharmacy at Rutgers, and you made a comment in your slides about breaking down those silos and reaching across departments, and I think that's absolutely valuable. There's a lot of efforts being done in small pockets, but I think the more that we come together, we don't, again, have to reinvent the wheel like you said. I guess my question right now is, the nascent technology, we talk about AR and VR and all these other things, they seem to be really super, super awesome and gets everyone excited. But in my opinion, they're sort of in that toddler phase where they're maybe not mature enough to be able to translate to the outcomes that you're looking for. So what are your thoughts on that emerging technology?
This is a super advanced question. And thank you so much for doing simulation work in the pharmacy realm. You pretty much nailed it. Actually, last year at the Simulation Society annual meeting, there was actually a week-long research summit dedicated to research in simulation, and there was a very large number of presentations that have to do exactly with that. What do we do with AR, VR, augmented reality, virtual reality, all of the different blends? And now, basically, in the journal, we're seeing papers that are being submitted that are sequelae from those presentations, right? So like, for example, review of augmented reality simulations in pharmacy realm or in surgery. So, and now that I'm actually looking at this evidence nitty gritty, you're exactly right. It's not quite mature. It's very heterogeneous. The outcomes are, like, frankly, all over the place, and most of them are low evidence. The thought, however, the reason why it's been so popular in the last 5 to 10 years and it's sort of exploded, because the thought was, well, if the simulation is so labor intensive, and as the earlier question addressed, like, it's really the faculty time, not the stuff. So if faculty time is the problem in simulation, and that's why simulation is expensive and resource intensive, then can we use pre-recorded, pre-designed, interactive, virtual reality, augmented reality modules, courses, whatever you make it, scenarios that could replace that faculty person? And as you said yourself, in my opinion, I don't think it's mature enough. It does have a lot of really interesting positive side effects, is what I would call it. Like, for example, you know, if we can get all of our pre-reading, as I call it, done in advance to the virtual reality module, like, let's just say we're doing postpartum hemorrhage from the pharmacy standpoint, we reviewed all the meds and their dosing, route of administration, contraindications. We reviewed postpartum hemorrhage protocols and which stage of hemorrhage requires what type of intervention. Like, if we actually made that module at NYU, because pre-reading was so expensive, like, we have to read so many documents to understand how complicated this management algorithm is. But anyway, if you could sort of take certain components of it and automate it and make it less labor intensive and have participants kind of get primed for real-time simulation in real life, maybe that's its biggest utility. But you're right, like, people are exploring it in a sense that, like, let's just replace it all. And I agree with you. I don't think we're quite there. We just don't have enough studies to show what to do with those interventions and how they work. So I think that's kind of where we are.
All right. Well, thank you, Dr. Lerner. Thank you for this excellent talk. We very much appreciate it.
I really appreciate the opportunity to talk, and happy simulations.
Thank you. All right, everyone. Well, we're going to leave it there, and we'll end for this morning. I hope everyone has a safe and successful day. Thank you.